Good afternoon, everyone, and welcome to Endo Hepatology session, third session. For the first talk, we have Dr. Sandeep Nijavan sir, and he's going to talk about endoscopic management of symptomatic gallstone disease in decompensated cirrhosis. Sandeep sir.
Dr. T.S. Chandrasekhar will also be chairing this session. So.
Good afternoon, ladies and gentlemen. At the outset, I'd like to thank Dr. Ajay, Sunil, and the entire team for the kind invite. I'll be covering the endoscopic management of symptomatic gallstone disease in decompensated CLD. Prevalence of gallstones is higher in cirrhotics as compared to the general population. It is around 25-30% because there is increased risk of lethogenesis in these patients. Pigment stones are more common, and why we are discussing, because there are challenges with anesthesia with perioperative complications in these patients. Why these patients, they have more prevalence of the gallstones? Because of chronic hemolysis in cirrhotics, altered bile composition, we have gallbladder hypomotility, decrease in bile acid synthesis, portal hypertension, which leads to hypersplenism and hemolysis, and autonomic dysfunction, which leads to dysmotility of the gallbladder. So, what are the presentations of a gallstone in a cirrhotic? It can be asymptomatic gallstones, 10 to 20% of the cirrhotics have it. Incidental dissection on ultrasound. Then symptomatic gallbladder stones, again 5 to 10% cirrhotics. They present with right upper quadrant pain, evidence of cholecystitis, evidence of gallstone pancreatitis. Asymptomatic CBD stones, 1 to 5% cirrhotics, and symptomatic CBD stones presenting as obstructive jaundice, cholangitis, and pancreatitis. So, what are the issues in CLD? The compensated child's A cirrhosis. If a symptomatic gallstone disease is safe to do lap chole, and there is no ascites, there is minimal portal hypertension, coagulation risks are minimal, so they can be subjected to lap chole. There are less chances of infection and cholangitis in these patients. But in decompensated state, the pain is blunted, the fever is masked, and there are diagnostic delays. Anesthesia is a problem, poor drug metabolism, reduced cardiac reserve. Portal hypertension, there are enlarged collaterals around the gallbladder. There is intraoperative risk for increased bleeding. Then high perioperative risks are there because these patients have coagulopathy, ascites. There is a poor wound healing, and there are more chances of cholecystitis, empyema, and perforation in these patients. And hepatic decompensation post-surgery, they land up with actually ACLF post-surgery. There is precipitation of jaundice and encephalopathy. So, what are the impacts of a liver disease severity? In a decompensated state, the prevalence of the gallstone is more. In child A, the presentation management is similar to a non-cirrhotic, but in child B, patients who are having decompensated state, the chance of bleeding, infection, poor wound healing is there, and there is moderate to high risk of anesthesia in these patients. So, anesthesia risks are there because of the hepatic metabolism, because of these agents. Reduced albumin is there, so a free drug is available. Ascites, pleural effusion leads to decrease in the lung compliance. Difficult ventilation, risk of aspiration is there. Encephalopathy is because of sedatives, which can worsen the mental status. There's fluid overload in decompensated state. They present with hypo or hyperglycemia. HRS patients can be precipitation of hypotension AKI in these patients. Anesthesia risk, of course, is there. Propofol is the preferred drug. Again, the dose of propofol required is low, and benzodiazepine and volatile anesthetics are contraindicated, not to be used. Antibiotic use in child A don't need prophylaxis. In child B, always a prophylactic antibiotic is recommended. And those patients who present with a complicated gallbladder problem like acute cholecystitis, GB perforation, gangrene, empyema, they require higher antibiotics according to the culture. Antibiotic use in ERCP, again, prophylaxis initially is not required, but if there is incomplete drainage, patient of PSC and strictures, cirrhotics in a decompensated state, prophylactic antibiotic followed by higher antibiotics. Asymptomatic gallstones, there is no question you have to actually give them a conservative treatment because most of them they remain asymptomatic. Only 10 to 20% become symptomatic. And child's B, C, of course, there are problems with doing cholecystectomy, so it has to be avoided. So, asymptomatic gallstones is conservative treatment. Symptomatic gallstones, depending on whether the patient is in compensated state or decompensated. In a compensated, as good as doing a lab chole. Otherwise, in a decompensated state, you have to individualize the decision, and risk of complications like cholecystitis and empyema is there. So, lab chole should be done after correction of INR, thrombocytopenia, ascites to be controlled. Actually, it should be a multidisciplinary evaluation of these patients. And if the patient is very sick, unfit for surgery, even a percutaneous cholecystostomy can be performed. Symptomatic gallbladder stones, advanced decompensated state, it is a state of sepsis and organ failure. So, conservative treatment as far as possible, even in symptoms, avoid surgery unless absolutely indicated. Multidisciplinary approach is the care of management. Percutaneous cholecystostomy can be done. Definitive surgery only when transplant is planned and cholecystectomy can be done during transplantation. There is a high perioperative mortality, so a percutaneous cholecystostomy or EUS guided procedures can also be done in these patients. So lab chole, safe, preferred in childs A and B. If the MELD score is less than 13, there are modified techniques like Hessian entry. That means you actually, before entry, do a layer by layer dissection, followed by making an entry port. Or if there are collaterals there, then you can go to the left side. And by this, you can actually, doing the fundus dissection first, you can avoid the collaterals. And in child C status, you have to optimize the patient before subjecting these patients to surgery. A predictor for choledocholitis very strong if the patient presents with cholangitis, bilirubin is more than 4, and CBD stones are seen on directly on ultrasound. Then it is a very strong predictor. Strong predictor is when the bilirubin is between 1.8 to 4, or there is a dilated CBD on ultrasound of more than 6 millimeter, and moderate is age more than 55, clinical evidence of gallstone pancreatitis and abnormal liver function test other than the bilirubin level. So, if somebody has got a strong predictor, directly ERCP can be done. If presence of both the strong predictors, again direct ERCP. If there are no predictors at all, no further tests are required. If there are few tests intermediate, then one has to take use of MRCP or US to confirm the diagnosis of choledocholitis. Asymptomatic CBD stones, because of high risk of cholangitis, jaundice, secondary cirrhosis, and sepsis. So, child's A, elective ERCP can be planned. In child's B, ERCP should be done after optimization. In child C, avoid elective ERCP unless until there is a strong indication of cholangitis. If it is a mild cholangitis, maybe a conservative treatment because these are very poor even ERCP candidates. Symptomatic CBD stone, child's A and B status, ERCP is safe. In child C, uh, we have to actually correct the coagulopathy, platelets, ascites, hemodynamics before the intervention. Broad spectrum prophylactic antibiotics should be given. ERCP is the gold standard in these patients, and US guided biliary drainage should be done if the ERCP fails, and if the patient is very poor, very sick, he is not a candidate for ERCP, even PTBD can be performed. So, what is the preoperative workup? Platelet counts should be transfused if the platelet count is less than 50,000. If INR is more than 1.5, FFP is to be given. Correct hyponatremia, hypokalemia. Take a serum baseline ammonia level. If it is higher, then it has to be treated before subjecting these patients to ERCP. Always have a group cross matching done because there is a risk of bleeding. Optimize these patients if they are in decompensated state. Ascites, do paracentesis, give albumin. Encephalopathy, give lactulose, rifaximin, and sedatives. If there is HRS AKI, hydrate the patient, give albumin, avoid nephrotoxic drugs. Prophylactic pre-procedure antibiotic is always recommended if the patient has got child B and C status. As far as the electrosurgical current is concerned, it should be a cut mode, and it should be given in short bursts, because it leads to a better hemostasis in these patients. It reduces thermal injury, and less muscle contraction and tissue tearing is there with pulse cut mode. And pulse cut mode has shown that there is a reduced risk of post-sphincterotomy bleeding in cirrhotics. Sphincteroplasty, again, alone for small CBD stones and a decompensated CLD with a bleeding risk, is the treatment for choice. A partial sphincterotomy followed by sphincterotomy, sphincteroplasty, is for large CBD stones, and it has been shown that sphincteroplasty leads to decrease in bleeding, avoid thermal and cutting trauma. It is effective for smaller CBD stones, and even for it has been shown even for larger CBD stones that the requirement for mechanical lithotripsy is less. So, especially it is beneficial in patients with Child's B or C status with more INR more than 1.5 or platelet less than 50. But there is a slight increase in chance of pancreatitis in these patients. Post ERCP bleeding, monitor the patient for hematemesis, melena, hematochezia, monitor for a drop in hemoglobin, monitor for tachycardia, hypotension, pallor post procedure. They should be managed with PPI infusion, IV fluids, uh, FFP platelets, transfusion, blood transfusion according to the requirement by tech. Then endoscopic hemostasis can be done, and one can go again inside if there is a chance. On monitoring we find bleeding, we can do clipping, APC, epinephrine injection, radiological embolization if endoscopic procedures fail, and ultimately surgery if patient has got a life-threatening hemorrhage and is not responding to endoscopic and radiological procedures. So the take-home messages are that the gallstone disease is more prevalent in cirrhotics, and the management is more challenging in cirrhotic patients, especially those who land up with decompensation. One should stratify these patients to Child's A, B, and C, because Child's A, it's safe for laparoscopic cholecystectomy and ERCP. In Child's B, it's a high perioperative risk, so it has to be individualized for the patient, and multidisciplinary management is essential. And ERCP plus sphincterotomy is the preferred method for CBD stones over surgery because of less invasiveness and better tolerance. And pre-procedure optimization is vital to correct the coagulopathy and ascites and encephalopathy in these patients, and to keep the hemodynamic instability before any intervention like lap chole or ERCP is to be done. ERCP remains the gold standard for symptomatic CBD stones, and it should be used with caution in patients with Child C. Initially, optimize the patient and do it. And US guided drainage should be done if the ERCP fails. And PTBD is always helpful in those patients where even the ERCP is contraindicated. Antibiotic prophylaxis is important in the setting of a decompensated cirrhotic who is undergoing the invasive procedure, and it is minimally invasive approach with a tailored management is the plan for better outcomes in decompensated patients, and a multidisciplinary patient specific decisions improve the safety and prognosis in these patients. Thanks for patient hearing. Thank you.
Yeah, thank you, Dr. Sandeep. We can have few questions before the next talk. See, the major problem in these patients is that the gallstones, cirrhotic, especially the Child C or maybe Child B also, the surgeons will refuse to do surgery, majority. And especially when there is a decompensation in the form of ascites or maybe a few episodes of the encephalopathy or bleed, and we'll have to be very, very careful. Even the ERCP is quite risky, and when you are trying to clear the CBD, suddenly there is a bleed, a small sphincterotomy, and there is a bleed. And management of the bleed in such patients is very, very difficult. As a last resort, what you can do, you can put a metal stent, and that will take care of it, and then later on you can resort to the surgery. And then the another problem which we face in these patients is you do ERCP and you inject some contrast, and the contrast goes into the gallbladder. And following day, your stent is working. You have taken out the stone, but the patient complains of fever, a high grade fever. You look at the gallbladder, there is a empyema. So there are two ways of tackling it. One may be put a stent into the gallbladder, or maybe you ask the radiology colleague to do the cholecystostomy. So these are very difficult patients. A patient may come with a large gastroesophageal varix. See the GOB2, a huge GOB2, and this is decompensated cirrhosis. Now it is very difficult to decide whether to deal with the GOB first or get a cholecystectomy first. So these are difficult decisions to be taken by the surgeons. Yeah, Dr. Arka.
So thank you for an excellent talk. My question is, what's your opinion about say long-term gallbladder stenting without scheduled stent exchanges, either US guided or transpapillary? There's a recent paper in endoscopy also on the transpapillary GB stenting, and we've also presented that. So it can be bridged to cholecystectomy at the time of transplant in decompensated cirrhotic patients. So what's your take on endoscopic GB stenting?
That's very right, actually. All these patients, those who are decompensated, actually, you can have a bridge for transplant. So if they are presenting with cholangitis, you can push in a stent and you can keep it till the time that transplant is being planned. And when you are doing a transplant, then that time cholecystectomy and removal of CBD stones.
See, it's easy to say that wait till the transplant. How many patients can afford the transplant? See, these are patients, a lot of patients come like this, and you can't keep on putting the gallbladder stent for indefinitely. So this is a major problem. So 90% patients, only 10% will be able to undergo the transplant, or even lesser than that. So, and every maybe 1 month or 2 months they will require. So how many procedures you will do?
So without scheduled
those who
stent
are
exchanges.
prospective
Without
candidates only
stent
that-
exchanges, we place a GB stent, maybe two if required, and then leave it without scheduled stent exchanges until and unless the patient lands up in a complication.
If you leave it, they are going to die because they will come in the sepsis, and either you plan maybe regularly, or if you are leaving this patient with a already decompensated cirrhotic, comes in sepsis and he will die. It will be very difficult to take him up for the ERCP and then exchange at the time when he comes in sepsis.
Dr. Virender, your point is well taken. Those who are the prospective candidates
Yeah,
will
those who are-
promote that. Those who are not will closely follow it up. In a crisis, just a stenting does the magic, and maybe a stenting into the gallbladder. Maybe, as Dr. Virender warned, you should have a close follow-up. You leave it like that, the patient gets the false security, may die of sepsis.
No, no,
I think
close follow-up
both
is
points
required.
can be. Last question for the.
Yeah. So I agree with Dr. Virender sir, because some of the patients, they have the CBD stones with gallstones, and they are having repeated cholangitis, and they are not willing, or they don't have resources for liver transplant. So the best option, I think, will be just do a stent exchange at every 3 months. And because their lifetime is, it's not very prolonged, it can be, say, a couple of months, a couple of years only. So I think that can be the
actually,
best practice.
If you are
In
talking
this
of
stage,
the
actually,
CBD
you have
stone,
to optimize the patient. Once the patient is coming in cholangitis, simple stenting you do, and you call the patient after 4 to 6 weeks, and you do the permanent procedure for that patient. Remove the CBD stones once the patient gets better.
Yeah, but again, then you have to put a stent, and then you have to keep it doing it.
I think you can't keep on exchanging the stent. That is not the mode of approach.
Yeah.
Once the crisis is taken care, then you have to what Dr. Sandeep Javan said. And the last comment by Dr.
Yeah, I
Jayanta.
think I'll agree with Dr. Arka in saying that if there is decompensated cirrhosis, its patient is a transplant prospect, then transpapillary stenting is done, and then we later on do the surgery. If those patients who are not decompensated cirrhosis and are not a prospect for surgery, patient land up with cholecystectomy, a transmural gallbladder drainage, there is extensive data on that. That a transmural gallbladder drainage is good enough, and that takes care of everything that the problem is there. Yeah.
It's a very good the topic you have chosen, Dr. Ajay. This is a very common problem. I think a lot of options are there, As you said, maybe immediately ERCP do that, lab chole, the patient, child's A, B and C is the one what you highlighted very good. And maybe I can recall the best paper award in the World Cup endoscopy. In a patient of child B cirrhosis, they did the, as you suggested, US guided cholecysto duodenostomy. Then they got the first prize, I'm telling, 15 years before. I think a lot of options, it all depends on the, what kind of expertise we have that. I think with this, we'll move on to the next last session. Dr. Harpreet, you want to introduce the topic and the speaker?
Dr. Koenka, I think he can deliver his talk on endo ultrasonography guided biliary drainage versus ERCP for malignant obstruction.
Thank you, Dr. Harpreet, and good afternoon, everybody. Thanks, Ajay, for incorporating this talk in the basic liver meetings. I think endoscopy is gradually encroaching onto the hepatology and in the right way. So I'm happy to see a significant number of people in the last talk. I can be feeling happy that they have come to listen to me, but I know that they are here for the valedictory function. Doesn't matter. My job is to talk to you about EUS-guided biliary drainage versus ERCP for malignant extrahepatic biliary obstruction. Now, I'll just, I know everybody knows about these techniques, but if you talk of EUS, this is the one which is most commonly done, the EUS CDS, in which we approach from usually the first part of duodenum, puncture the bile duct, and then put a stent, which can be either a Axios lamp stent or it can be a normal SCMS. The other technique is EUS antegrade stenting, where this is a patient in which there was infiltration at the D1, D2 junction, as you can see, and so it was impossible to do an ERCP. And what was done was segment 2 puncture, and then an antegrade stenting was placed, as you can see. Now, the other techniques are hepaticogastrostomy. I think the second most commonly done procedure in my unit. And we again approach it from the left hepatic duct after puncturing the segment 2, and you can see how the cholangiogram is obtained, and then a stent is placed from the stomach to the left hepatic duct, sorry. Now, the other technique can be rendezvous technique, and the guide wire, the approach may be either from the left hepatic duct or from the bile duct, from the duodenum, and then, as is shown in this video, where there was a large diverticulum which did not allow us to do an ERCP, we approached it through the bile duct, and the guide wire was put into the, you can see a pancreatic stent which was pushed prophylactically, and then the guide wire has been placed, which is taken care of, and then it's withdrawn, and then a procedure is completed by rendezvous techniques. The two other methods for EUS are hepaticogastrostomy with bridging stent, where you bridge between the two ducts, right and the left hepatic duct, and more recently hepaticoduodenostomy, which is less commonly done, where you approach the right hepatic duct from the duodenum. Now, the stents for the EUS-BD, plastic stents are no more used. For EUS-CDS, it's either LAM, which can be any of the LAM which we talk about, or fully covered stent. And for EUS-HGS, it is usually either a partially covered stent, which is preferred, or a fully covered stent. LAM is usually not used for this procedure. Now, ERCP, we have been performing for almost 40 years now, and there may be a disclosure which I must say that I have been performing ERCP for 40 years, whereas in our unit, EUS is being done actively for only 5 to 7 years, EUS therapeutic I'm talking about. So in the ERCP, you can place a single stent or double stent. There is a controversy whether double stent should be side by side or stent in stent. Some data that stent in stent may be slightly better than duodenal stent with the side to side stent. So the factors to be considered when you are dealing with a malignant extrahepatic biliary obstruction are these 5. Whether you are doing it for palliative purpose or preoperative purpose, whether you're going to put a single stent or multiple stents, whether the papilla is accessible or not accessible is the most important factor, and what's the cost issues and the expertise. I won't touch upon the last two parts because it will vary from center to center and depending on your practice. But let me talk about the other 3 issues. Preoperative biliary drainage, whatever we talk about, we always say that preoperative biliary drainage is not to be done, it doesn't help, but the real time data shows, if this video runs, leave it. Like real-time data shows in USA that more than 50% of the patients in US database received preoperative drainage. This is a cruel fact of life. This may be for cholangitis, intense pruritus, delayed surgery, neoadjuvant chemotherapy. Some people will do it for high bilirubin value and when you're planning a more than 70% liver resection. Now, let me first make this a strong statement that use of EUSBD in preoperative drainage is not supported by strong evidence. People have been doing hepaticogastrostomy for this, but this is a statement which is made as late as 2024 second half. Now, let me look at the other issue, that whether we're going to put single stent or multiple stents, and it will depend on the location and the type of the stents. For distal bile duct, which constitutes a significant proportion of patient, and then we have perihilar, which can be type 1, where the confluence is intact, type 2, type 3A, 3B, and 4. I'm not going to go into details. I'm not sure that you all know about it. For the distal bile duct stone, a single stent is required. For type 1, single stent is required. For type 2, you may use a single or double stent. For 3A and 3B, usually double stents. For 4, usually multiple stents. Now, for hilar block, which is 2 or more than 2, it has been shown that by multi-center studies that bilateral stents are better than single stents. So now let me come to the most important issue, which is accessibility of papilla at ERCP. If the papilla is accessible, we have two possibilities, ERCP and EUS. If papilla is not accessible, which can be either because of post-surgical situation or gastric outlet obstruction, then EUS is usually the preferred modality, and then you can go for enteroscopy, percutaneous or edge technique. And of course, in this also, if ERCP and EUS are not possible, you can go for a percutaneous technique. Let me further dissect it. Accessible papilla, single stent required. So in this case, we have ERCP and EUS. EUS, you have 4 modalities: CDS, which is most commonly done, antegrade stent, hepaticogastrostomy, or rendezvous technique. Now, the main controversy in this situation is between ERCP and CDS, and I'll address this in the next few slides. And of course, in the multiple stents, ERCP with bilateral stenting is still the standard of care, and I think there is no controversy about it. If it is not possible because of technical reason, then we have 4 options: ERCP on one side with SGS on the left side, ERCP with antegrade stenting, hepaticogastrostomy with bridging stents, or hepaticogastrostomy with hepaticoduodenostomy to approach the right duct. These are the 4 options, and of course, if all these fail, we should not forget the percutaneous route as well. Now, if the papilla is not accessible and you want to do an EUS as the primary modality, you can do all these: cholericoduodenostomy, hepaticogastrostomy, antegrade stenting. I would also touch upon the edge technique, which gradually becoming popular. We don't have much experience of this, but when the stomach with the papilla are extruded or excluded from your path, then the best way is to approach this through a puncture with the EUS guided. And what you do is that you approach this secluded segment by just like you do a CDS, that you put a stent, Axios stent or lamb stent, and then through this you balloon dilate and then complete the ERCP in the normal way. So this is edge technique, and edge technique has been shown to be better or not inferior to laparoscopy guided ERCP in this situation. So now let me now talk about the most important issue and most controversial issue now. What is the status of EUS versus ERCP in distal biliary obstruction? And when we talk of distal biliary obstruction, EUS, we are primarily talking of CDS. So there are 2 meta-analyses published in 2024 towards the second half, one in endoscopy, this one, and one in the GI endoscopy. Now, interesting part is that they started looking at 443 papers in this and 467 papers in this, and they could only find 5 good studies in this and 6 good studies in this. All 6 good studies in this included these 5 studies. So what I'm trying to say is that there are very few studies which have really looked at this comparison available today. So this is the first meta-analysis which looked at distal biliary obstruction, mostly CDS versus ERCP, and then what they found is technical success, clinical success, adverse effect, and 1-year stent patency was similar. What was difference was reintervention, 11% in EUSBD compared to 17% in ERCP. And whether it matters or not, EUSBD was 2.36 minutes faster than ERCP. Whether it really matters or not, I'm not sure. Now, what was more interesting is that LAM had better success rate, better results, but when you look at patency, it was decreased patency, possibly because of foot bolus impacting on the LAM lumen. So these are the 5 studies which included in this. I'm not going to details of this. These were mainly in pancreatic cancer, some in cholangiocarcinoma. 3 of them we used CDS. 4 of them used only CDS. 1 used SGS as well. And if you look at stents used, 3 of them used SCMS, where 2 used LAM stent. So there was an opportunity to do sub-analysis as well. Now let me talk about the second meta-analysis which I talked about, published again in 2024 in Endoscopy, which included one more study, and that was a Chinese study. And again, it shows that the technical success and clinical success was same. The main difference was in complication rate, and I'll talk about it next. So when you look at the outcome determinants, when you compare these two modalities, you look at success, which can be technical and clinical success, patency, complications, and reinterventions. Now, this is to summarize the first meta-analysis: technical success, clinical success, overall adverse effect, 1-year patency, severe adverse effect, and reintervention. The only difference was in reintervention. Reintervention was less with EUSBD compared to ERCP. Now, this is the second meta-analysis, which in detail looked at adverse effects, and adverse effects were more with ERCP than with EUSBD, and this was mainly because of pancreatitis. Pancreatitis, obviously, we all know, would be more with ERCP than with EUS, but this was compensated to a great degree by more cholangitis in EUSBD group compared to ERCP. So the cholangitis was more in EUSBD. Now, when you do a subgroup analysis of the first meta-analysis, the better results were in the last 3 years studies. All the studies which had more than 100 patients, those were multi-center, and most importantly, where the CBD diameter was more than 16 millimeter. So they had either pre-selected, or ultimately the result, it shows that the CBD diameter was more than 12 millimeter, and mostly they had 16 millimeter in their patients which were subjected to this study. Now, what is the limitation of meta-analysis? This we must see very carefully. We must not take the words as it appears to be. There is huge heterogeneity of results. Look at the heterogeneity, which is I square: 64%, 80%, 32%, 99%, and 98% heterogeneity. That means results are not matching one study with another. There is publication bias, particularly on severe adverse effects. There is randomization issue in 2 of these studies, and this has been brought out in the supplement table which is given in the study. So these 2 studies had randomization issue. What is very interesting is Hong Kong study showed the ERCP success rate was 76%. So any good center cannot have an ERCP success rate of 76%. So I looked at this study very carefully. They had included non-accessible papilla also in this group. So I think for a good study to be comparing the two, you should exclude non-accessible papilla and then only talk about comparing EUS with ERCP. And significantly dilated bile duct was selected in some of these patients. So I'll just end another minute or two to save the time for validatory function. Now, whenever we evaluate these studies, we must look at the design of the study. And this is another study, again from Asia, which is saying ERCP plus EUS versus percutaneous transhepatic biliary drainage for malignant biliary obstruction in multi-center observational open study. So what they did is that they compared the ERCP group with a combination of EUS, which include all the we compare PTBD with EUS combinations. And they found that the EUS was much better than PTBD. But then when you look at this study, the PTBD was done by 2.5 millimeter catheters compared to 10 millimeter catheter by EUS. So you can't compare apples with oranges. I think these are the studies which sometimes take us away from the real facts of life. And when we talk of hilar blocks or malignant biliary obstruction, we should not forget about IR. Though this was not my talk, but I thought I must say that IR is there to help us in advanced hilar strictures. And if you go through the radiology literature, they have enough literature to show that advanced hilar strictures are possibly better treated by IR people than by us, either at EUS or ERCP. Now, this is the present situation in Norway. They have just a few months back showed that 596 ERCP procedures done with very satisfactory results. So I must agree that EUS BD evaluation has taken place. Some years back, we talked about this being a dangerous position to be done by experts like Dr. Jayanta, and in rare circumstances. We had improved accessories, and that made us to believe that it should be done by experts only, and in failed ERCP. Then we have RCTs, which replaces PTBD in expert centers. And finally, today we are talking about, can it replace ERCP in biliary obstruction? Now, so take-home message from my talk is, and I will stress on each sentence, for non-accessible papilla, EUSBD is a preferred modality today, no doubt about it. For accessible papilla, ERCP continues to be globally standard of care. I would strongly recommend that. In spite of some concern about existing data, EUSBD, mainly CDS, is emerging as primary alternative intervention when tertiary level expertise is available. And we are in the transition phase. We have not transitioned completely as yet. Pancreatitis with ERCP and biliary leak and cholangitis with EOS-BD remain the major challenges. Hilar block requiring multiple stents are still first managed by ERCP. Thank you very much.
The talk is open for discussion and comments, please. Dr. Samantha, if you can add a few things, please.
Jayanta, you have some experience.
So the point is very simple that when we are talking about unresectable malignancies, probably in those cohort in distal biliary obstruction, USBD might be an alternative option as compared to ERCP. For the resectable component, we are obviously not talking about now. We do not have enough data to talk about doing USBD for resectable cases where later on a pancreatidorectomy is planned. However, having said that, I'll point out two data that have come up from the surgical series, sir. One is from the French cohort, and this Dutch cohort also have published that even after a LAMS placement for a USCDS, pancreatidorectomy was done, and I mean, there is no added major complication. This paper came up just this year in Endoscopy 2025. But having said that, I completely agree with you that for resectable cases, preoperative biliary drainage, still it's ERCP, ERCP, ERCP. For unresectable distal malignant biliary obstruction, probably USBD might be an option, but again, more data is probably required to kind of understand that. And for Hilar, as you aptly pointed out, the whole game is different, because in that situation, probably ERCP is still the better way to access both the ducts and then kind of do it.
I'm so happy Jayanta agreed to everything I said.
I think it all depends on the expertise available. Are we dealing with a proximal biliary obstruction or distal biliary obstruction? And the third thing is how much you want to utilize the IR. That is very important.
How much you want?
Interventional radiology. That is also, we cannot, before doing pre-cut, some people say that ERCP failed and I go ahead with the US. That is also a point to be taken very seriously.
So what you're rightly pointing out, Dr. Chandrasekhar, is that when do you define an ERCP failure? I think that's very important. Now, this, what was disturbing to me, and I talked to Anthony once, that how can your ERCP group have 70% success rate? So he said, that's the data what we have. So I think we need to look into it. Possibly they included a lot of patients who had duodenal edema, duodenal infiltration, and because of that, the ERCP success rate came down.
See, the ERCP is still a preferred choice, and I'm talking of the resectable growth. In that, if you do the EOSBD, you will have to put the metal stent, and the cost is quite high. You cannot put a plastic stent there, but if you are doing ERCP, you can put the 10 French 2 stents there, so cost will come down definitely. So if you are managing the unresectable, then of course you can compare the two. But if it is resectable, then for some time only you are putting the plastic stent. You can put 2 plastic 10 French stents, and there's huge difference in the cost.
Sir, in case of unresectable hilar stricture, when papilla is not accessible, would you prefer PTBD or USBD?
I think that there are 2 or 3 options in this: US, PTBD, as well as enteroscopy. Sometimes your papilla may be accessible by doing an enteroscopy. So sometimes we'll go with enteroscopy also. So I think all these 3 options are there, and the discussion should be based on your local expertise. I don't think we can go on the data. You may have a very good intervention radiologist and who will do a much better job than in the US. So I think we have to look at the local expertise and the cost. We really do not have data. I can be corrected, but I don't think we really have a data on hilar block where the procedures have been complicated, has been competitive. Now, only thing you have to understand that US, if you have to drain both the ducts, right and the left duct, it's not an easy job to do.
See, if we are doing dealing with the hilar block, and you are doing a PTBD, it's a hell of a job, and so many problems for the patient. This is not a one-time procedure, so they will have to do the PTBD on one side, another side. After 1 week again they will call, and then there is a problem again and again, and sometimes the slippage of the catheter. So life becomes hell. So for that you have to do definitely the USBD is definitely better in the hilar blocks.
I tend to disagree with Dr. Virender. It all again depends on the expertise. We have been doing PTBD in single procedure. Both the stents have been placed, and I don't think we can make a sweeping statement like that, that it's a hell of a job. I think we need to have more data before we say that. I think I would only summarize that it all depends on the local
Yeah,
expertise.
it all
It all-
depends on the expertise. I think.
See, the problem comes when there is ascites.
Oh, yeah, those are specific
yeah,
situations. We are not
in
talking about
patients with the ascites, malignant obstruction, you can't do a PTBD.
I would again add one more line before we finish is that even for pre-operative palliation, in our unit we use metal stent rather than the plastic stents. So our preference is to use a covered metal stent if you're talking of distal bile duct rather than the plastic stents. If we are doing a hilar block, then we use a plastic stents rather than the.
I think
Rather for the hilar block, you should use the metal stent. Do not go for the plastic stent.
We're talking of hilar block pre-operative.
Yeah, pre-operative. See, the cholangitis is so common if you put a plastic stent. I don't know why the cholangitis part is not highlighted, especially in the hilar block.
See,
If it is type 1 block, that's fine.
see, we have
You
to
can do
remember.
it.
We have to remember
I
one
think,
thing. I totally agree with you so far as the cholangitis is concerned. But let me tell you, if we put uncovered, if we put covered biliary stents in a hilar block, sometimes we can cause more problem because the anatomy of the bile duct.
But who is
varies from
talking
person to
of
person.
the covered metal stent in the hilar block?
Yes.
There is no question. The covered metal stents in the hilar block, you are blocking the other side. There is
That's
no
why I'm saying that we
question.
I think Dr. Mahesh and Dr. Virender, Ajay would agree with me that you want to resolve all these issues. Next meeting, INASL, you should have a panel discussion of radiologists,
In January,
surgeon,
January in Calcutta, we will invite
surgeon,
Virender Singh.
endoscopist, and oncologist also. I think last comment you want to make anything, Sandeep, before?
No, I think this debate will go on forever.
Yeah,
Actually.
forever. And
But it depends on the local expertise if it is there. I think PTBT is a good choice in higher blocks. And as far as EUS guided drainages are concerned, it requires a skill.
I think Jayanta, you have a last comment. Anything quick?
Jayanta has agreed
One
with
word
me.
comment.
Jayanta has agreed with me.
Harpreet? Yeah, you all meet in ISG.
He wants a
call.
discussion in ISG.
Okay, I think it is a wonderful
already enough of
meeting.
it, I think.
I put it in record, one of the best meeting I have attended. Very well organized, both academic, cultural, and time to time, the monitoring was very good. 1:35, we have to finish it. We are done that, and we are all going for the valedictory. I think we should give a big hand to the organizers under the leadership of Dr. Ajay and Sunil Taneja. It's coming from my heart. Having organized so many conferences, I can put it in record. One of the best, very, very organized. Thank you, Goenka, for your wonderful talk.
Thanks, Ajay, Sunil. Thank you.